So I'll call to order now the meeting of the Potter Valley Healthcare District Hospital Corporation for Wednesday, February 26th. Rosie, can you please give us a roll call?
Yes, Director Cox. Here. Director Creel. Here. Director Gallagher.
Here.
Director Pimentel.
Here.
And Chair Nugent.
Here. There's nothing to report from tonight's closed session. Now I'll ask for any agenda modifications for consideration from staff.
We do have a request to add recommendation to pass a motion for a radiology service provider agreement. It is somewhat urgent, like it is done in a timely manner.
And that is item number 6 in your stack.
So this is a possible supplemental item for tonight's meeting, and it does require a motion to get it onto tonight's agenda as item number 6. So
Second. Thank you, Director Gallagher and Cox. I'll take roll on this item. Director Cox. Yes. Director Creel. Yeah. Director Gallagher.
Yes.
Director Pimentel.
yes.
And Chair Nugent.
Yes, thank you. So now we'll move on to the public comment on matters not on tonight's agenda. Rosie, is there any raised hands online for people wishing to comment on items not on tonight's hospital corporation agenda?
No hands on mine.
Anybody in the public wishing to speak on? Okay, no. I will close down the public comment and I'll move us into comments from board members. Any comments from board members? Get to that. Speak. All right. Okay, seeing none, I will now move us into the consent agenda. We only have one item tonight. It's to pass a motion to approve the minutes of our previous meeting in January 29th. I do have to go out and get public comment on the consent calendar. And so I'll ask if there's anybody wishing to speak on this one item online, raise their hand.
Chair Nugent.
Yes.
The item number 6 that we're adding a supplemental is going to be a consent item as well. And you can put that into this, I believe, for approval, like a consent item, consent calendar item. Or do you want to separate that out?
Yeah, I'll have that be the last agenda item, just so, in case we have any questions, Matt, okay, sweet. So anyone wishing to speak on the consent agenda, on item number 1? Seeing no hands, raise the line, no hands with us. In person, I'll close down public comment and I will entertain a motion for the consent agenda.
I'll motion.
Second.
Directors Creel and Gallagher, I'll take roll on that item. Director Cox. Director Creel. Yes. Director Gallagher.
Yes.
Director Pimentel.
Yes.
Chair Nugent.
Yes, okay, thank you. Item passes unanimously. So we'll move on to our discussion items for tonight. And our first discussion item tonight's agenda is the Medical Executive Committee report for February 2025. This is an extension of a report that we received in closed session from Dr. Christopher O'Grady, Chief of Staff. And we do have to go out to public comment, but just want to check if there's any other questions from the board about the MEC report. Okay, so now I'll open up the public comment on the Medical Executive Committee report for February 2025. Any raised hands online?
None online.
Any raised hands with us in person? Seeing none, I'll close down the public comment and I will entertain a motion.
Move to approve.
Second.
Cox and Creel, thank you. I'll take roll on this item. Director Cox.
Yes.
Director Creel.
Yes.
Director Gallagher.
Yeah.
Director Pimentel.
Yes.
And Chair Nugent.
Yes. Okay, so now we're moving on to item number 3. It's the Chief Executive Report. Steve, whenever you're ready.
Just 1 moment, please. Okay,
Yeah,
I think you're ready.
all right, thanks, Rosie. Thank you, Chair Nunez. So leadership update for the month of January. First item is that we have been given this opportunity by one of our local publications to We're gonna do a monthly, what we hope will be monthly op-ed in Lookout on healthcare and the things that are coming at us in the healthcare landscape, with the new administration and everything else that's going on in the public sphere and how it will impact the people of Pajaro Valley Healthcare District and Watsonville Community Hospital specifically. So we were able to publish our first one last week, and we are already starting to think about the next topic, which will likely be diving into the ramifications of possible cuts to Medicaid or Medi-Cal, as it's called in California. Those cuts, we don't have any idea what they will look like yet. We do know that the federal government, at least the budget the House has passed, looks like it has some pretty steep cuts being asked for, but very unknown as far as what those cuts will be and what areas, and therefore how it would impact our reimbursement, our services, both here locally and specifically to our hospital and our healthcare district. So we're staying as close as we can to this, as well as with our elected officials, letting them know what certain cuts might look like. And we'll try to write about this in as much detail and understanding as we can so that we can keep the public informed. Aside from that, these last few weeks and months have been tough here. We've had some operational challenges. So we know about the cyber incident that we had in November that physically, in terms of the systems, only took a few weeks to get everything back up and running, but it's taken still ongoing right now in terms of the recovery efforts from it, right? We're still working on getting reimbursed for the patients that we saw, about 2,000 patients that we saw during the downtime, still getting all of that coded and submitted and billed and reimbursed for. So that has put a further strain on the cash flows, which we've talked about plenty here before, and you're all well aware of those challenges, and Julie will talk more about that with the finance report. We had a challenge with our Medicare payments where we have completed everything that CMS needs, but we are waiting for them to release a number of weeks worth of payments back to us, which when we get it, it will be very helpful from a cash flow standpoint, but they have been withholding that, and we hope to get that within the next week or two, but we don't know exactly because that's CMS, and there's obviously a lot going on in Washington, DC, and they're not well known for being super fast anyways, without all of the challenges going on there. We have had multiple, not downtimes on our phone and fax system, but significant challenges with them, with lines being dropped and with faxes not coming in or going out in a consistent manner that has really been a challenge operationally, particularly for those departments that rely on calls coming in, calls going out, emergency department, labor and delivery, and so forth, receiving faxes for orders for patients coming in for lab radiology, things like that. The most recent one, AT&T found a flooded switch that was down the street that was causing the issues. They fixed that, replaced that, but in the meantime, it's still, we don't know how reliable it's going to be until it has challenges. Again, it's been okay for the last couple of weeks, knock on wood, but it has been a challenge. We do know that we need to fully upgrade the phone system to the latest technology of voice over internet protocol. And that's a significant cost. We're looking at different funding mechanisms for that, whether we can use bond money for any or all of that. Probably not all, but maybe some of it, depending on the infrastructure of it. And looking at other potential borrowing financing options for the phone system as well. The next two are definitely eventually going to be fixed long-term by the bond proceeds. The chiller that is really critical in the MRI has had challenges and was going out, and when it doesn't work, then you can't run the MRI machine, and then you can't take care of patients in that way. And we did have a pretty significant multi-day downtime on the CT scanner. We have one CT scanner right now. When we complete our work with the bond proceeds, we will eventually have two. But for now, when the one goes down, that's pretty critical to the emergency department and other services that we provide. So this has all been really hard for the team in the last few weeks. So everybody's feeling it. We're doing our best to stay together and put our arms around each other and take care of each other, patients. The team does an amazing job of doing the best they can with that, and it's been hard. But I just want to acknowledge that for our team. It's been some work. And I can answer questions about that now or come back to it. We do have the January data. So this is the 2025 new version of the dashboard. So we've got some greens and reds, right? When we had that at the beginning of last year, we had some reds at the beginning, and we were able to work through those and get most of those improved throughout the course of the year. So quality of patient experience, HCAHPS, we flipped over to likelihood to recommend the hospital. Last year, our green target was the 65th percentile. This year, it's the 75th percentile. So we got to raise the bar for what green is. And we're somewhere between that 50th and 75th percentile, closer to the 75th, with 75.4% of people saying they would be very likely to recommend the hospital to friends and family. And then safety for our patients and our teams, it's one thing on the dashboard, whether it's going to be red or green, but it's two really important numbers. One is our hospital acquired conditions for our patients, and the other is injuries to employees. So we had 15 hospital acquired conditions last year and 55 total injuries to staff members last year. That's all injuries. That's the ones that were just reported but didn't become workers' comp issues or days missed or anything like that, plus the ones that were more serious that might have become workers' comp and might have resulted in days missed. And so in this January, we had one more than we did last January. So that on the rolling 12 months means our number went up. So it went up by one. So that makes us red because we're worse than we were last year at this point compared to last year. We do, as we did with hospital acquired conditions last year, want to reduce all of this by 50%. That's our goal. It's a big stretch goal, particularly to reduce it on hacks by 50% again after we did it once. But we want to eventually get these to zero. So we want to do as much work as we can on this. Clinical services and access for January. So this is just the month of January. We were green ahead of budget for outpatients served, and just barely red, just 3 admissions short of where we were January of last year. But quite a bit behind where we had budgeted for January. For talent and culture, our target performance is the 75th percentile nationally for hospitals, and we're at that. So for the rolling 12 months, we're at 84%. You might also hear this as a 16% turnover rate. And then the score survey has opened up this week. So that's going to go on for a few more weeks, and then probably not in March, but April or May, we'll have the results back from our beta partners, and we'll be able to look at those and discuss them and do action plans around them. With all of the operational challenges that I mentioned before, that's gonna impact these score signs. And then Julie will do her report on the financial status for January. We did have about a $1.4 million loss for January. And then Rosie was going to show you the new district website, if you haven't already seen it, that Nancy and Rosie have been working very hard on.
Let me pull that up. You mentioned we have a new website for the district that we launched last Thursday, actually went live. And, Steve, would you like to give a tour or would you like me
I thought you were going to, because
Okay.
you helped create it and you're driving the bus.
Will do. Okay. Of course, we do have information here for both the district and the hospital in terms of board meetings. So all board meeting material will be listed here. We have been fortunate enough to gain local support and have received a handful of really awesome photos of the district, spanning from Rio Del Mar to the south side of Watsonville proper. Every time you visit the homepage, you will receive, or you'll see a different picture. There's 3 rotating through. So just keep that in mind when you visit. We have a news section here, which you can just quickly see the most recent or view all the items that we have loaded. And we do, as you can see, have this, we do not have this translated in Spanish all completely yet. We do have a few articles here that seem to be Spanish too. And then the calendar will show any events we put on, whether they be board meetings or other type of events. You'll always see the upcoming here in the tray, and if you view the full calendar, you can see them in that format. And of course, clicking on the district logo always takes you back to the homepage. The agenda and minutes section does have 2 tabs, upcoming meetings. Everything that's been preloaded for the year is here. And then as meeting materials become available, they are loaded here as well. And on the back end, I'll just note this is very easy for us to update. So we're very, very happy with this new platform. And you can go to recent meetings, see everything the district and the hospital have ever done, watch videos and read minutes and agendas and other such items. We have a link to the foundation here for those who'd like to donate. I have a contact us page, which is a form that is sent to a few of us in the hospital. And we have a direct link out to the hospital itself. You'll notice these items here on the left, and I will just go ahead and jump into those. Those are primarily accessed through the About link on the header. And you'll see a number of different links here on the page, everything from what is a district to information on the hospital, the clinics, like coastal healthcare, and again, the foundation as well, along with links to those pages. You'll see information here on the board members. Each of you have a page, and there is a direct email form, which anyone may fill out and looking to contact you rather than obtaining your email itself. We also have information here on the community health fees assessments and also the external partnerships that we are seeking to obtain. We also have a new governance section, which again has the board members' information, but also has information on both the district and the hospital. The whole premise of going with a new website and with a company to help us better lay out all these pieces was to become more compliant in a number of ways. And so one of those ways is to be able to have more of our documentation available to the public. So I'll just show you, I'll show you here the establishing documents. For example, we have the information on SC 418 and we have our bylaws. And we have those for the hospital as well. You'll notice fewer sections here as the hospital is a nonprofit versus the district, which is California State Special District. They didn't have different requirements. Any questions or anything anyone would like to see specifically on the big screen?
Any questions for?
Another one that's photos.
I just like the banking book, looks like a huge piece of work.
Well, the labor of love. Make love the new platform.
Yeah. This is great.
Thank you,
This is
Rosie.
great
Great job.
job.
You're welcome, and thank you, Nancy.
Yes. Nancy.
So that was all from my presentation. I'm happy to answer questions, and I know that Phyllis and Matco have their updates as well.
Any questions for Steve on his report? Or with Matco, I do have one, but I think you sort of answered it. It's just the phone system. I think when we were going through the measure and what can we not use, the
Yeah.
proceeds of the bond that this was approved. The like rule of thumb was, can someone pick it up and move it from the facility easily, right?
Right.
Like is it a fixture or whatever the right term was? I'm wondering, so I hope that most, if not all of that cost can be covered by Measure N. And sometime this year, is that not gonna be the case, Matt? No?
No, we reached out to bond council and they confirmed that that was not eligible for bond.
So financing plans, and I would imagine it's some.
So we're looking at other financing options for this. There's a state financing program that is specific for equipment, telecommunications, computers, things like that. That is not it's not an easy application process, but it exists. So it's definitely something that we're working on pursuing, particularly for the phones.
Matt, when the bond council, what was the reason, if you can remember, why this doesn't,
It didn't meet the criteria, so it's not.
so someone physically pick it up and move the phones? Okay. Okay, any other questions for?
It's like, it's with voice over IP, it's the phones, but it's also like servers.
Yeah.
Now, which again, they've told us that servers can be picked up.
To another facility, yeah.
It sounds silly, but can you bolt stuff down?
I mean, if we have to bolt most things down in the hospital for seismic compliance,
Right.
so that's not the definition, unfortunately. It's more of a universal, what absolutely is a fixture of the.
I'm gonna express delayed gratification. I was just getting lost on the website here, so very cool. Super easy to navigate, so thank you for getting that there. I really love the agenda format, how it's laid out. It's gonna be a really good way to help educate the public about our district, what it is. So thank you. Thank you.
Cool, Matt, whenever you're ready.
Sure, thank you. Just a couple of things to kind of Steve's operational report, regarding the CT MRI outages. We did have a mobile CT unit delivered today. The GE engineer is working on getting the applications, updated and set up so that put into service. Steve mentioned the long-term solution for both MRI and CT. The radiology team has been reviewing options with different vendors and has been traveling to sites to test equipment and determine which equipment may be the best for our facility. So we're excited by that opportunity, as they are excited about the opportunity as well. So we're getting close to, they're in Oregon currently, looking at equipment up there. And once they come back, we believe we'll be able to start zeroing in on which vendor may be the best solution for our facility. On the pharmacy front, Jennifer was here briefly but left. I wanted to just highlight the fact that 340B, we've talked about it here previously on the outpatient front. When we first implemented in September through January on the outpatient side, we had a cost avoidance of $127,000 in that grouping. And she is going to be launching, we are going to be launching 340B on the inpatient side, which is a greater opportunity for us on March 11th. So very excited by what that means to us from a cost avoidance standpoint. On the material side, we are working with Vizient and trying to get creative on ways to get them out here to do a supply chain assessment for us. It's typically a 4 to 6 week process. We think we've found some solutions that won't be direct out of pocket costs to get this done. So we're going to pursue that. And the best case scenario for that would be the end of March launch, kickoff end of March. The goal of that would be optimizing our supply chain processes, making us more efficient and looking at all the potential that we may have for savings and shifting us there as quickly as possible. That's it. I just wanted to thank, Steve mentioned this as well, but the disruption between CT, MRI and the phones and the AT&T service into the building was really rough on staff. I just wanted to take a moment to acknowledge the hard work staff did to try to work through those challenges, and patient volumes didn't drop, patients were not affected, and it was fairly seamless for the most part. In most cases, I shouldn't say seamless, the CT and MRI disruption was pretty intense, but staff really powered through it, and we'll be in a better place once we have this equipment upgraded and refreshed. So everybody's excited by that possibility of happening soon. Happy to take any questions.
Any questions for Matt? Or it's always funny how the money comes in, right, Matt, for the fix, and right before you can start on the fix, something always breaks down. It's funny how these things work. Okay, I think, Phyllis, are you ready?
I am. So just to tag on to what Maxwell was saying about the CT, we are super excited about the trailer and excited about the opportunity to have redundancy in CT service. Not having a functioning CT scanner in an emergency department is unacceptable. And you may hear from others in the county, so I'll just say it here, that it has been a very large burden on Santa Cruz County and EMS systems and Dominican in particular. And I want to thank their partnership, because this has been a lot of leaning in by many people in the county and the EMS authority, and with Dominican supporting us. And we're working mostly to keep our patients safe and to make sure we have good triage from the field criteria to make good decisions about where patients would go. So having a functioning CT scanner is 100% something that we must always ensure we have. So I appreciate all the work that's been put into getting that trailer here and getting it up and running. So in addition, talking about applications and diagnostics, we submitted our EPCI application for the cath lab on Valentine's Day. We put little red hearts on the FedEx envelope. So to remind you, we are licensed in the cath lab, but we have to apply for interventional capability. That is the application that went in February 14th. So there's a pretty long runway for that, but getting it in is the first step. So very excited to get that done. We are looking at first case of non-interventional activity in the cath lab around mid-April, looking at April 15 on tax day, because we can use the money. So that's something we're working towards with our cardiologists, and I have already started having some intense conversations with cardiology, hospitalists, and emergency physicians. So super excited about that. We are working through with Kaiser Permanente, who's been supporting us with our hospitalist agreement. As you may recall, one of our hospitals groups pulled out January 10. Kaiser has been backfilling that, and we are working on looking at a solution, longer term solution for that. So we are in contracting conversations with them. Wanted to report out on our palliative care team. We are just about ready to go next month to see our first patients with our palliative care team. This is an inpatient physician run team with nursing and social worker support. And we hope to expand this to the emergency department, and something that our community sorely needs, looking at end of life care for our community. So very happy and excited about that. And I think that's it for me.
Any questions for Phyllis? Phyllis about the CT.
Can interventional radiology use the same place, and is that part of it?
In the cath
Part
lab,
of
you
the
mean?
discussion, yeah.
Yes, yes. And actually, we are having some conversations about what those interventions would be, because we know the first EPCI is going to be a ways out, but we really love to warm that cath lab up with some other interventions, for sure.
Okay. Okay.
Sure.
Any other questions? Thanks, Jeff. Any other questions?
For that EPSI or that.
EPCI. I could tell you what it.
I think it's gonna be a while.
It's gonna be.
Years, months.
No, months,
Yeah.
months. It's a physician-led team that comes out and does a full assessment. And so we really would like to get, as I said, the cath lab warmed up using the equipment, getting people with the muscle memory of using all the things, and then go to that. It's kind of a higher level study.
Any other questions? Can I ask you about the palliative care team, who's on that? And then, are we working with our faith-based partners in the area as well to bring in
I'm so glad you brought that up. You know, we don't have an active volunteer chaplaincy, and I think we did for a while, and as I understand, it kind of just kind of fell apart. And so we have some volunteers who are really interested in connecting us with those faith-based organizations, so we can get an actual schedule
Yeah.
of volunteer chaplains, because spiritual support is a huge part of any palliative care program. So we have Dr. Janet Nagamini, who will be our physician leader, who's wonderfully engaged and has a lot of experience. And then we actually have nurses that we have hired from Santa Cruz Hospice, who actually are our med-surg telenurses, who are kind of signing up for shifts to be palliative care nurses. And then we are actually looking for a social worker to support that team. So we can have a physician-led triad of physician, nurse, and social worker to round out our patients.
That's fantastic.
Yeah, we have, at Elder Day, we do have a volunteer who comes in and does a sermon every other Friday.
Oh,
I
that's
believe. It's just great for the patients there, you know.
It certainly is.
And, so love to connect
For
you with
sure.
any of our faith-based partners of all different religions from our area. Love to have that part of the care team.
Yeah, yeah. So much.
Any other questions? Okay. I think that concludes the CEO report, and I'll go out for public comment on this. Any raised hands online? Anyone wishing to speak on any of these items?
No one online.
Anyone in person wanting to speak on the CEO report? Okay, seeing none, I'll close down the public comment portion and move on to the financial officer of the financial performance update. Julie, whenever your presentation's ready, and you're ready.
Great, thank you, Connie.
Mhm.
So as Steve mentioned, we did lose money this month. We kind of expected it, planned budget accordingly, so we don't have as much of a budget to actual variance, but we do have a loss that we've got to, you know, we will work on making up through the course of the year as we get into busier months. If I can get the first slide, please. So here's the almost $1.5 million loss, about 1.4 on the EBITDA front. You know, the challenge this month really was, I know I tell you almost every month it's net operating revenue, and it certainly was this month, but kind of for a different reason. We had some decent volume, but a lot of what's coming out of here is the cyber attack and the way payments are flowing in as we are kind of recovering from that. Right now, our accounts receivable is much heavier government weighted than it normally is, and that will smooth out over time as we kind of get through this backlog. But really what that means is we go to value the AR based on the types of accounts that are in the AR, when it's much more government weighted than it is commercial weighted, then you kind of feel the drag in your estimation process. And so that's a lot of what we're seeing here. There is a little bit that also just relates to the fact that we budgeted conservatively for QAF payments because we don't know beyond QAF 8, the hospital assurance, quality assurance fee, what QAF 9 is going to look like. So we budgeted, but we're really only booking anything related to QAF 8 at this point. We also have budgeted for initiatives like the cath lab that we had during the budget thought we might be opening sooner than we are. And so we'll have a little delay in the ramp up there. So that's some of what you see in the budget variance around net revenue. Most of the expenses were favorable to budget. Some of that savings come from not having initiatives fully up and running. We have a slight savings in supplies, but we budgeted heavy in supplies, still with the need to do everything we've been talking about with hopefully a busy and consultation. What we did see in our supplies is most of the supply expense this month was really clinically related with some higher implant costs because we had a pretty good surgery month. Some of the lab and pharmacy costs just related to certain patient care needs, and a little bit of repairs and maintenance supplies, as you can imagine. Next slide. So on the statistics, you know, kind of comparing the budget, slightly down in admissions, but, 321 is, as you'll see in the next slide, it's one of our better months. The average daily census was almost 36, and if you remember, towards the end of the year, we were more in the low 30s. So we did see the uptick there. We had less patient days because we had a lower length of stay at 3.46. And we did 56 surgeries this month, so on the inpatient side, so slightly better than budget. On the outpatient side, we did exceed budget both on the non-ER and the ER visits. With about 94 ER visits a day and 100 non-ER visits a day. And we did 122 outpatient surgeries. The bulk of what you see in the variance on the outpatient surgeries would be the fact that the cath lab is not open. Next slide. Just a quick comparison to January of last year. So you can see that our admissions are higher than last year. Our observations were down from last year. Our census is slightly down from last year, but as I mentioned, better than it has been. But our length of stay is significantly lower than last year. I also have the deliveries here. I think I missed them because I wasn't, when I was putting the slide together, I didn't remember what the budget number was for deliveries, but good month on deliveries, 73. And, most of the outpatient visits or outpatient statistics, we are exceeding last year's January. Next slide. So here's what I was saying about admissions. As you can see, there's an upward trend in January 25 at 321 admissions. It is really a high point for us over this 13-month stretch, but a nice kind of increasing. It's one of the things that, we focused on, and Steve has entered it into the dashboard this year, that we want to grow inpatient as well as outpatient. We staff an inpatient-based hospital, and so it's to our benefit to be able to derive some of the efficiencies out of having more inpatient volume. Next slide. Here's outpatient and ED visits. What you see here, the blue is the non-ER, and that's got a slight upward trend, even though January is a little lower than some of the other months, but it is slightly higher than last January. The orange, which is your ED visits, while we're always busy there, it's kind of a more flat storyline. We're fluctuating usually between 95 and 105, so visits a day. Next slide. This was kind of the nice story when I kind of redid this slide. It just kind of stood out to me. The nice increase we've had in deliveries over the last 8 months. The low point there being in June, when we were at 48 deliveries up to the 73 that we're at in January. And so, it appears we're seeing some recovery in deliveries where they, over the last couple of years, we had seen more of a downward trend. Next slide. Total surgeries, the orange being the outpatient, the blue being the inpatient. I'll start inpatient, it's got some spiky months, but the trend line is fairly flat. Outpatient, and it shows a downward trend line, but I think if you really took last February out, which was an anomaly, having 150 outpatient surgeries in the shortest month of the year, if you took that out, I don't think you would see such a drastic decline. I think it would be a much flatter line here. So as we get a couple months out in February, it drops off here. I think you'll see that flatten, and hopefully we'll start the upward trend with our CAPA other services. Next slide. So inpatient payer mix. This is going to seem like a little bit of a disconnect because I just finished talking about how the accounts receivable was heavily government weighted and impacted our valuation. And that's because at that point I'm talking about some accounts have already paid and some accounts are still waiting to be paid. The good news here is in our inpatient payer mix, we actually had one of our strongest commercial months. We have 18.7% commercial, and, normally we're averaging 14, 15, 16, and thinking when we get into the 17, 18, it's a good month, and we'd see a lot of that more in the summer months when, this is a great place to come for tourism. So very pleased to see that we had strong commercial mix, on the inpatient side in January. Next highest, of course, the Alliance at 42%. And, everything else is relatively close to normal. The last couple months, we've seen a little bit of dip in Medicare, but something's got to go down to get those commercial, to make the numbers work here. So that's what we're seeing on the inpatient side. Next slide. On the outpatient side, we're pretty much seeing our normal trend. We had 23.6% commercial. That's just right where we tend to run between 22-24%. So that's pretty normal. Just short of 47% from the Alliance and 18.5% from Medicare. So again, I think this is pretty much it's normal for us. So the one other thing, and I don't have a slide, but I just wanted to spend a couple minutes and talk about the recovery efforts from the cyber attack at a very high level. Just going to give you some numbers. During that 3-week period of downtime, we had 1,826 patient accounts, and that totaled about $27 million worth of gross revenue. We went through the process of, first we had to register all those accounts. Once the system was back up, then all the teams had to work on getting the charges in. That is, kind of 100% done unless some stray charge shows up, which those occasionally do, even in good times. 99% of those accounts are coded. Then once they're coded, they're sent to our Guidehouse, which does our billing and collections for us. Of the accounts they've received, 88% of those claims have been submitted, because once they get them and they put them out to submit, they sometimes get some rejects and they've got to work through that. So 88% of the claims have been submitted. 54% of the claims submitted have been paid. And so, we still have about 50% to be paid. One of the things I saw in just looking at some of the numbers in a little more detail, and it makes sense that you kind of get the easier claims out the door first. So some of the longer length of stay, higher dollar, more complex claims that take a little longer to code, may have more edits on the billing, are some of the accounts that haven't paid yet. So there is still money to come in the door from that. We're still, while we have most of that backlog, most of the way through to at least claim submission, that work in itself created a backlog with the current work. And so we are still higher in our days discharges not final billed, but we've brought that down significantly. I think we hit a high point at one point of about 20 days discharge not final billed. Our norm is 5 to 6, and we're sitting at around 11 right now. So we still have, we've cut it in half, and we still have another half to go. But a lot of really good work going on there. And I just wake up every morning looking at the cash, waiting for the floodgate.
Yeah.
Or at least trickle in a little faster.
Yeah.
So that's where we are with recovery. And I can take any questions.
Questions? Or Julie? I have a couple questions, Julie. So for one is more like measuring trends, and then the other is just a general question and patient commercial mix. So the first one is about our volumes. I'm wondering how we're measuring some of the impacts to the volume from the current presidential administration, folks not wanting to come to the primary care doctor or to receive care, to put also vulnerable positions. Are we looking at on a month-to-month kind of rolling basis, or looking at year prior, or
Steve, I'm not sure if we had that sort of conversation to, I know it's only been a couple of months, and so it's tough to tell what the overall impact, but.
We are always looking at trends, as you see, I'm always looking at how we performed over the last 13 months, how does this month compare to this month last year? February, I'd have to go back and remember what February 23 is, so I haven't measured February per se. January, you could see that we had more admissions and we validated that some of that, because I was like, gee, the ops went down, but we validated that some of that is because we're just doing a better job, not letting them get there, because sometimes those are still, more our social type observation admissions versus really a need to be here.
Understood.
I think the harder part of that is when you see a change in your volume is really isolating the cause of that, because we don't really have a way to capture that cause. It would be more anecdotal if people were saying it. I think, you can see in the outpatient visits in January, and what we've seen across can you go to the one slide that has that one here, that one. So blue is the outpatient visits, and the high spike there is in October. So it was really before.
Right.
It's not necessarily clear that the November, December, numbers are impacted by
Causation versus correlation. That's
I would actually venture to say it's probably more operational. We've had CT issues, we've had, MRI staffing issues. That would probably be more what you're seeing from that high spike in October. Then, there's always also the holidays and things like that.
And January 25 is higher than January.
January 24,
Yeah.
The ED is busier.
Yeah, I think.
We did look at the ED volumes like the 3 weeks before the inauguration and the 3 weeks after, and it was about 5 or 6% higher after. Just one data point,
Right. I think Steve and I have had conversations about this, about, like the cases becoming more acute from people not going out and receiving social care, right? So
For care.
average length of stay maybe going up higher as the year goes on, or I just wondering how we're measuring some of those things.
that's definitely one way to measure it.
Yeah, and usually when we see a length of stay start to climb, we try to get into a little bit more specific about the cases to understand, isn't something that could be caused by people not having care, sometimes it's more of a, situation, at home with their caregivers, willingness to kind of move on to the next place that they need to go if it's a SNF or something. So we always do try to dig in when we see spikes in length of stay or even long length of stay individual cases.
And in case mix index. They also sort of something
Yeah.
to keep track of.
Yes, and we do watch that. And we have not seen that tracking up yet, but we need to see that.
And then for the inpatient, commercial mix, Julie, do we know the distribution of those cases, like why that jumped? I think it was maybe 4 or 5 percentage points.
Well,
This last, I'm just wondering if they're like
when you think-
births or, I think it was at the other side.
Yeah, this probably would not be births, as Phyllis was mentioning, we had higher Kaiser volume this month,
Okay.
and
I think
some of that-
next one, I think. No, maybe the next one, right there.
Yeah.
That's
I don't have a lot of specifics on that.
interesting to see. Okay, cool. That's all I had. Any other questions? Or do have to open up to public comment? Okay, Rosie, I'm trusting your eyes. Any raised hands online? Wanting to speak on the CFO report?
No, we have the one.
Anybody in person want to speak on the CFO report? Okay, I'll close down the public comment. I'll move us on to item number 5, and it's the 2024 Potter Valley Healthcare District Hospital Corporation Consolidated Audit Engagement. Julie, back to you.
Okay, this is just to bring forth that it's time to do another annual financial statement audit. We have the last couple of years used JWT Associates, and they've done very well for us. So we are engaging with them again to do the 2024 audit. We're in the early stages to get that started with the anticipation of bringing back a draft audit report to this board no later than April. And it's $30,000, just up slightly from last year's fees. And we're just asking for formal approval.
Any questions from?
No, I just want to comment. I think we've received a clean up all my opinions, right, then here, we received a clean audit from them, so it doesn't mean I want to keep them for that, it's more about they're auditing us at a very high standard, we've done a good job. So I'm grateful, this is not a comment about contract, I'm grateful that for the work that's being done, to keep us in a position to have clean audit year after year.
Any other questions?
Okay, I'll go out to the public. Anybody online wishing to speak on this item?
No, fine.
Anyone in person wishing to speak on this item? Okay, seeing no raised hands, I'll bring it back and I'll entertain a motion on item number 5. Approval.
I'll second. Director Pimentel and Cox, thank you. I will take full on this item. Director Cox? Yes. Director Creel?
Yes.
Director Gallagher?
Yeah.
Director Pimentel?
Yes.
And Chair Nevius?
Yes. Okay, so we'll move on to item number 6 now. This is the agenda item that was added earlier in the meeting. It's the agreement for a radiology service provider. Matco, I think you gave us a brief introduction to the item, but anything else you wanted to add before we have an opportunity to ask questions?
No, this is requesting approval to continue and finalize negotiations with the group prior to the next meeting where we'll be bringing that agreement. As you know, our ABIS agreement ended and we are currently servicing the radiology department with locums providers, mostly local. So this will help us get to that next page of permanent, reliable, improved service support of the radiology department.
Any questions before I open up for public comment on this item?
More of a question about how we came bring to choose this particular.
So we've, several groups provided proposals. We have representatives from our medical staff, interview the groups, leadership team as well. The proposals were very comparable as far as cost goes. We're still negotiating, so this is a kind of not to exceed number here. We solicited feedback from the radiology department staff, leadership in the department, medical executive committee leadership, and our group. So we're really wanting to make sure that the fit is good for our community and our organization. We believe we will settle on what we believe is the right group.
Any other questions on this item? I can pause a little bit. I know this is a, yeah, looking at this.
Do you happen to know the, like the median reimbursement for RVU for, is it on here? Sorry.
That's okay. So our estimated reimbursement for RVU is a little over $45. So this would be essentially like an income guarantee, making up the difference between reimbursement and their expectations. So we're guaranteeing them an income of X per RVU. Collections, we estimate to be a little over $45. Would be making that difference. Like an income guarantee agreement, similar to what we see in NSDPS. Costs are going up at every turn.
I'm trying, I'm not in that.
Look at it's estimated to be a 462,000, or no, sorry, 497,210 increase over annualized. If we end up at that 76.
So like MGMA data is, the median is D3.
Right.
Rather than cost, is the new group like, do they have interventional docs? Is that- yeah, part of
They,
it?
they do, they have 21 providers, 21 provider group currently. They have 7 facilities that they service currently. They have their own PAC system. It's a well-structured, well-run group.
And are people gonna be on site each day or have they got?
Yes, they will be recruiting as well for our site. So initially, they may not be on site every day, but ultimately they will be on site daily.
Any other questions?
What is the term of the agreement that we're looking for?
Per
You
year,
can say it brings to you in negotiation.
well, 3-year duration. I think that gives us some stability, gives us opportunity to get the group acclimated to our environment. I've spoken to some providers from our previous long standing group, RFG, and they had good things to say about this group. So
That's good.
the group has switched leaders. It's currently, our group was familiar with their prior leader, but they're also familiar with the group and they had great things to say.
Okay, any other questions for opening up the public comment? Of course, we can always ask more questions. Not sure if we'll have public comment, but we'll have opportunity. Okay, so I'll open up the public comment. Anyone online wishing to speak on this item?
Not online.
Anybody in person wants to speak on this item?
Okay. Any other questions or any comments about this? Or if there are none, then I'll entertain a motion for this item.
So moved.
Was the second, Director Cox, Director Gallagher and Creel, thank you. I'll take roll on this item. Director Cox. Yes. Director Creel.
Yeah.
Director Gallagher.
Yes.
Director Pimentel.
Yes.
Shannon, yes.
Yes. Okay. So that brings us to the end of the Water Valley Healthcare District Hospital Corporation.